we are excited to host part 2 of our medical student webinar series that is focusing on the different kind of aspects of cancer care, and looking at the different specialties is the highlight for this specific webinar. And so we are very thankful to have incredible educators, leaders, clinicians from medical oncology, surgical oncology, and radiation oncology this evening with Dr. Jill Gilbert, Dr. Melissa Hogg, and Dr. Rachel Jimenez. And so the format for this evening is each of them is going to have an opportunity to talk about why they chose their specific oncologic specialty. And then after that, go into a typical week for them of what that looks like from inpatient work, outpatient work, kind of research or education aspects. And then at the end, we'll have a chance for everyone to ask some questions to all of our fantastic attendings. Okay, so first we have Dr. Gilbert. Dr. Jill Gilbert is a professor of medicine and medical oncology at the Vanderbilt Ingram Cancer Center, and she specializes in head and neck cancer as well as thyroid cancer. She completed her medical degree and residency at the University of Alabama, Birmingham, where she served as chief medical resident before she moved to Baltimore for her medical oncology and hematology fellowship at Johns Hopkins. In addition to treating head and neck cancer patients, she develops clinical trials for head and neck cancer patients, and she also conducts research to understand the patient's immune responses when receiving targeted systemic therapies. She is very dedicated to medical education. Some of her previous roles have included Director of Hematology Oncology Fellowship at Vanderbilt University Medical Center, and as well as Vice Chair for Professional Development at Vanderbilt University Medical Center and Education Committee for American Society of Clinical Oncology. And a lot of my friends and colleagues that have gone into medical oncology have had incredible opportunities training under her, and I'm so thrilled for her to be here with us today. So Dr. Gilbert.
Thank you, Stephanie. That was very kind. So thank you guys. This is a really exciting time, and for all of you. And the beauty of medicine as a whole, as a field, is that you have choices. And this is a great opportunity to try on different hats. It's low risk, and you get to really kind of see what fits. Sometimes there are people who go down a certain path and even have a residency, and they realize that's not a great fit. And we've had people from rad-onc go to med-onc, or med-onc go to rad-onc, and surg-onc go to, so it's, again, the beauty is you're forever adjusting. So the reason I chose medicine / medical oncology is several. Number one of my influences for going to medicine was actually, I love creative writing and I love the spoken word. And so for me, William Carlos Williams, who is an amazing author around the turn of the century and a physician, wrote wonderful short stories, and it captured my attention, not just because the quality of his writing, but also because of the intricacies of humanity that he described in his short stories. And I frankly wanted to be a doctor like him. And thus I thought, oh, I'm going to be a family medicine doctor. So you go in with these ideas. It didn't take me long, maybe 6 months in, to realize that's probably not what I want to do, but that being a doctor was still absolutely the thing. Then, I don't know if you guys still use it, but Robbins' textbook of pathology, I think it's a classic, right? So I'm dating myself. It used to be, I wonder if I have it right here, a hardback covered book. Now you probably have digital. But that thing was kind of beautiful to me in that it really tied together the understanding of pathophysiology and pathology and how that works in mechanisms of disease. This was literally a book that I highlighted multiple different times, whatever. I mean, it's not like I chose to do that for fun. Clearly I was studying, but at the same time, it totally made sense to me. And it spoke to me in terms of this idea of dealing with multiple organ systems and how they interact together, not only understanding the nuances of each one, but understanding the link between them. So that made me say, I'm going to go into internal medicine because I wanted only adults. I realized I was not procedurally oriented. So I didn't want to do surgeries. I didn't want to deliver babies. Hated that. I wanted to be thinking about things, and I wanted to deal, again, just with adults and with the idea that there are things that are going to cross different lines that allow me to not actually, in some ways, make a choice. And so when I was in residency, I was an intern, and my first rotation was hematology oncology. And for me, it was malignant heme inpatient. It allowed me to take everything I pretty much had learned from Robbins and also from AIs. We used to call them AIs, now sub-Is, whatever. And then apply it to the patient. I mean, sadly, back in the day, these were patients who, had horrible side effects of treatment, had cardiac toxicity, had nephrotoxicity. We haven't gotten away from all that. We're a lot better about it. And then the other thing is, it just allowed me to think and put a lot of stuff together. Now, what I will say is, during that time when I trained, AIDS was real. And we had, and I don't mean HIV, I mean full-blown AIDS. And so we had wards and wards of patients who were AIDS patients. You didn't have even AZT at the time. And so you were dealing with these medical conundrums and things that we had never seen before in this country on this frequent basis in terms of infectious disease. So it came down to, for me, some of the beauty that I loved in oncology was also in ID at the time, because it was sort of this thinking person's specialty who didn't want to be a proceduralist, who really liked the mystery. The difference between the two was that I saw that Med-Onc was gaining a lot of traction in terms of new discovery. And at the time, frankly, though it was being done, and we can thank Fauci for a lot of that, it was not quite as publicized that there were going to be all these amazing breakthroughs. And so ultimately, I chose Med-Onc. And the reason is, I love practicing medicine. I love all organs, systems. I love the depth of practicing medicine. I love the parts when medicine overlaps. I love a mystery, the ability to solve cases. The other thing that I do a lot of unknown primaries, and I love that. And it's the same thing with ID. I love that, but I also really liked the rapidity of the science in medical oncology. I wanted my practice to read like a New England Journal of Medicine case study. And I've actually kind of made it that way. While my basis has been head, neck, and thyroid, I do unknown primaries. I also do all the adrenal carcinomas, the PHIOs, and the paragangliomas, which frankly is an internal medicine person's dream, so to speak, in terms of, the things that you have to deal with when treating these malignancies. So that's where I came in. And for me, medicine was never a question. After 6 months in, internal medicine was never a question. ID versus Med-Onc was a question that got the differentiators were the rapidity of science and how that would fuel practice. So that's where I was. And honestly, never regretted it, never looked back. Now, while I used to do a lot of clinical trials, and that was the hat that I wore and the hat that I was trained for in fellowship, I look at life, I'm from New Orleans, so I look at life as kind of like the Mississippi River, right? So you can get on the river and be pushed down a current, but sometimes there is some changing in the current that allows someone to kind of go down a tributary. And so over the course of these many years, I've had a lot of different tributaries where, again, I got to try on a lot of different hats: medical educator, administrator, clinical investigator, etc. So I am now largely an administrator who does professional development in the Department of Medicine. But I want to tell you what life looked like briefly for all the different stops. So as a clinical investigator, and again, recognize there's a little bit of bias here because I'm in an academic practice. So, and I've never been in private practice or a hybrid practice. So you're going to hear what academics look like. As a clinical investigator, my day was this. My lab was the clinic. So I had 2 full days of clinic, seeing head and neck patients largely. And then I did 6 weeks on the inpatient service, which was a combination of having primary oversight of inpatients plus consultative service. During the other 3 days, I would be writing protocols, writing letters of intent, writing manuscripts, writing grants at the time. And so that went on, and working with collaborators, right? So that went on for probably about 5 to 6 years. And then my division director said, when I was up here at Vanderbilt, said, hey, you really seem to like medical education, which kind of fits based on being a chief resident, all that kind of stuff. So I said, well, I do. And he said, well, do you want to start moving into the fellowship director role? And I was like, that is a big change from what I thought I'd be doing. But if I listen to myself, the current of the river is not necessarily what I want to be. I'm going to swim off to the side and try on that hat. And I loved it. And I did it for 13 years. And so when I was in that role, this is what it looked like. And I also did section chief at the same time, which I do not recommend a combination of all this for everybody. But what that looked like is, again, 2 full days of clinic, 6 weeks on service. And the remainder of the days were split between some clinical research activities and then administering the program, which sounds kooky, but it's a lot, especially as the ACGME requirements and all that kind of stuff changed and our program continued to grow. So that's a full-time job that is about curriculum design and professional development and learning theory and how the two kind of fit together. And so that was a lot. So again, a lot clinical time and a lot of face time with the fellows. And there are a lot of things that you do in that role. Then at about 13 years of doing that, I had an opportunity. I actually crafted a job proposal because we are 1,000 faculty in the Department of Medicine, 1,000. And we never had a vice chair for professional development. And it was like, it's time. So I crafted a job description and I crafted goals and objectives for this position. And I pitched it to the Department of Medicine chair, who said, yes, we need that. That's great. Let's do it. So now I truly spend about, I do 1 full day of clinic. I do 5 weeks of inpatient. And then I spend the remainder of my time in this role that is creating professional development programs for faculty across the trajectory of their careers. So, and across the trajectory of different academic tracks. I do a lot of coaching, a lot of counseling, a lot of faculty affairs issues, which is very similar in a sense to what I did with residents, which is, you know, dealing with the human side of how people are coping with things and dealing with helping them to actualize their best self, whatever that looks like. Also helping them to recognize what it is that makes them tick and what is going to sustain them for their career. You know, medicine is a lot different than when I started out in terms of the business of medicine, the regulatory pressures, the presence of insurance and how that affects how we practice. The pharmaceutical industry is different. And so the question, and the thing we face for our faculty is, and that I work on in my role, is how do we keep people engaged, stimulated, and feeling excited about the next steps in their career. But in doing so, I had to give up some head and neck because I can't be the person who does everything, runs the trials and this, that, and the other. So recruited somebody else in, which allowed me as well to, again, go down a tributary and really lean into the medical mystery that I love, and living a CPC, New England Journal of Medicine, case on a daily basis in my clinic, and allows me to see a lot of unknown primaries, which are wonderful mysteries, and also to see the oddball zebras that nobody else knows what to do with. And I find it stimulating, rewarding, and fun. So several things. Medical oncology, because it was a beautiful mix of multiple specialties. The science was there. I saw opportunities to flex in different capacities in this area. And it is forever changing, forever engaging. And a big, big thing, I wanted to follow the patients from cancer diagnosis to, God forbid, death, but that does happen. And I am not a proceduralist. So it kind of made things easier. You don't want me cutting on you. I can tell you that. So I'll stop there and let whoever next.
Amazing. Thank you so much,
Thank
Dr.
you.
That was fantastic. And I love that analogy of the tributaries, because you never quite know where life's going to take you. I'll probably put that one in my back pocket.
Do it.
Okay. Next, we have Dr. Melissa Hogg. Dr. Hogg's a surgical oncologist at North Shore University Hospital and clinical professor at the University of Chicago, and she specializes in hepatobiliary cancers. She obtained her medical degree and completed her general surgery residency at Feinberg School of Medicine and McGaw Medical Center of Northwestern University, respectively. She then completed a surgical oncology fellowship, as well as clinical research certificate and medical education master's at the University of Pittsburgh. She is contributing in many ways to medical education, including as the head of the education committee for the Society of Surgical Oncology, the associate program director for the University of Chicago North Shore Complex General Surgical Oncology Fellowship, the director of the hepatobiliary surgery program at North Shore, and director of advanced robotic training for the Granger Center for Simulation and Innovation. One of her goals is to improve technical robotic surgery skills for residents and fellows, and she aims to accomplish this by creating medical education programs centered on proficiency-based robotic curriculum, where trainees will improve via the proficiency-based curricula and surgical coaching, which I think is fascinating, having a husband myself in surgery, and I'm not sure how kind of proficiency-based their things are with kind of technical training. So Dr. Hogg, thank you so much for being here, and take it away.
Yeah, thanks. Thank you for having me. And now I could get to people who actually do want to cut on other people and have that proceduralist part of their lifestyle. So I would say that I did go through life thinking I would likely be a surgeon, but didn't try to focus on it in my early years. So, I went to Notre Dame partly because they did not have a medical school. And I wanted to look into other options outside of medicine to see if that's something I would be interested in. And then once I did make it to medical school, I had a thought that, I wanted to be a surgeon, but that I wanted to give everything else sort of a adequate look and not sort of go down that, beeline towards that path. So I did a lot of, medicine rotations, et cetera, first, but then ended up deciding on a career in surgery. And part of what drew me to surgery was the technical nature, but also sort of the microcosm of life in the operating room. I love that. Environment where you sort of had sort of two parts to your day as a trainee, where you had what was going on the floor and what was going on in the operating room. And I really like the pace of surgery in terms of sort of immediate gratification, fast pace, quick decisions, et cetera. And so that kind of lifestyle called to me. So I think, that is definitely, a big part of going into surgery. And then once I went into surgery, I never thought I would go into oncologic surgery because cancer is hard, cancer is sad. And I actually never thought that would be something that would interest me and that I would be good at. Initially I thought I would go into vascular surgery, which has its own, trials and tribulations as well. But ended up, and I actually did 2 years of basic science research in vascular surgery, and I had sort of during that time period decided on surgical oncology. And what really led me towards surgical oncology, were two things. One is mentorship. There's really, everyone has great mentors and everyone has great experience, but I do think there's something special about people that treat cancer in terms of the way they perceive life, the way they perceive teaching, the way they perceive training, and just things in general. So I think the people that were mentors in the space of cancer surgery really spoke to me, and those were the people I wanted to be like. And then also the patients. I think one thing one of my mentors told me is never underestimate the gratitude of a cancer patient. And I do think that I was touched several times as a trainee, especially as a medical student, where I really felt like I could have a great relationship with patients in some of the most difficult times of their life, and make a difference. And I think that's what sort of drew me to surgical oncology. And there's sort of really many paths to be a surgical oncologist. I'll focus on the general surgery, but you could go the ENT route, the urology route, the orthopedic route, the gynecologic route, et cetera. But through general surgery, I did what we call a complex general surgical oncology fellowship, which basically is the breadth and depth of cancer surgery, where we do everything from, breast, thyroid, melanoma, sarcoma, everything within the GI tract, et cetera. And I'll talk about that more in a second, but there are other ways where you can designate your tract, where you could go to breast surgery and focus on that. You could go into colorectal surgery, focus on that, go into endocrine surgery, and focus on that. And then, for me, one of the things that drew me to surgical oncology is really not seen anymore. And one of the things was that some of my mentors started by doing some of the biggest operations, the liver, the pancreas, and then ended their career maybe 40 years later doing breast. And I thought, wow, what a great way to, see the depth of stuff. Now with specialization, you don't see that anymore. And I don't think you probably should see that anymore. And so, I did a complex general surgical oncology fellowship, which I trained in everything. And then I decided I wanted to focus more on the GI tract. And I do primarily liver and pancreas, bile duct, foregut sort of surgery right now. And that can be difficult in and of itself with, some really bad biology in terms of the patients we treat, and really difficult morbid operations in terms of the stuff that we do. And I always, and kind of what led me down that track versus maybe a different type of cancer was, again, mentorship. And, I just, when I was a fellow, the mentors that I had in the liver and pancreas space were just, the best that I had around. And actually, like, a lot of people want to do sort of pancreas and liver surgery, and I didn't go in there wanting to do it. And one of my mentors, like, that's why I want you to do it. It's like, you don't want the guy who wants to be the president. You want someone who doesn't want to be that and is sort of called to it. And just sort of, really tried to recruit me into that path. And I think that, one thing about surgery, and this is true in any profession, but I always think, I'm at a hybrid program right now where I'm a community practice with an affiliate with an academic center. My first job was at UPMC, so it was a academic place, with, many hospitals. And actually my day-to-day life is not that much different between the two systems. And I think a lot of that is based on what you want, what you look for, and what you want to spend your time doing. And so I consider myself, even though I'm at a community program, as being an academic surgical oncologist. And I think, when I recruit people, when I mentor people, I say, there's many different facets of a career. I mean, the clinical facet is one thing, and I'll get into my daily life, but I think probably less than a third of what I do is my clinical practice. However, that's what I'm passionate about. That's what drives me. But it's really the balance of everything I do that makes things go around. When I'm doing too much clinical and I don't get to the other stuff, I feel like I'm just a hamster on a wheel. When I'm not doing enough clinical and I'm doing the other stuff, I feel like I'm, an administrator or a desk jockey. So it kind of is all about finding the right balance. And so I always like to tell people you got to break things up into certain buckets. And I usually think of about 4 buckets. One is the clinical, one is the research, one is the educational, and one is the administrative. And so a lot of, I'm a division chief, so a lot of things go into administrative stuff, practice managers, staff, surgeons in my division, et cetera. A lot of the education piece, and that's a lot of what I'm passionate about. I'm associate program director of both the residency and the fellowship. I don't have time to be the full program director, so I like being the associate, so I could be involved in mentoring, involved in recruiting, et cetera, but not be involved in all the paperwork and all the time that our program directors put into things like that. And then the research. And I think what, just like the previous speaker, what really allows you to integrate research is to try and do research on exactly what you're doing clinically. So, I do have education programs in terms of advanced technical skills for robotics, as well as patient-centered and clinical outcomes, and, sort of cost analysis, et cetera, for pancreas and liver diseases. And so, that's what I do from an education standpoint and a clinical standpoint. So, it stands to reason that my research is on all of those different things. And being able to do that, you're able to kind of stay at the top of the game in terms of, what's going on in the, what's going on in the literature, et cetera. And I think a big part of that is also societies and meetings. So I sort of consider that society component as part of the sort of the research and education part of my job. And so just got back from the Society of Surgical Oncology that was in Atlanta last week, so was there, Wednesday to Saturday, doing everything from talking about to residents about why to choose certain programs, going to talks on the most next level, next gen sequencing for our malignancies, et cetera. So I really think that it's a combination of all of these things that really drive me. So like a day in a week in the life is and I again kind of have my practice schedule tailored to what I wanted to right now. So Mondays is my administrative day because then you could kind of start out the week laying out a plan for what needs to happen that week, any issues that need to be taken care of, sort of a gentle landing from the weekend, especially if you're traveling. I do a small little satellite clinic that's just an hour a day in the morning. And then kind of do sort of Zoom in the morning, the satellite clinic, then I come in and I'm in person the rest of the day. And then Tuesday, I have tumor board early in the morning and, basically a 10 or 11 hour clinic all on Tuesday. And then Wednesday, I'm in the OR. Thursday, I'm in the OR. And then Friday is my research day, which gets flexed to whether or not, if I have more surgeries to do, get flexed to add-on surgery. If I have more clinic to do, it gets flexed to that. I try to protect it as much as I can, because if you're productive in research and you give away your research day, then that's what you spend your night and weekends doing. And so I always tell people that I probably get paid for about a third of what I actually do, and I think that's very important in this day and age, because I think, people want to go into academic medicine and there's this, it's a privilege to serve. But in a new reality of kind of a quiet quitting and, doing the job that you're paid to do, it's a different calling. So, no one really pays me to be a program director or assistant program director. I think the PDs definitely get paid. And then in terms of the research, et cetera. But for me, having funding for the research I do, having resources for the programs that I build are important. And so I find that, being a surgical oncologist, allows you to, do many things. I feel like, a medicine doctor as well as a technical doctor. And I think the multidisciplinary care from tumor boards and discussions like this, having such a intimate interaction with medical oncologists, radiation oncologists, gastroenterologists, interventional radiologists, radiologists, as well as like psychologists, nutritionists, et cetera, genetic counselors. I think, we have so many teams, like our surgical team, our cancer team, our research team, our education team. And so I think in general, it's a team sport and it allows you to do so many different things. And, it's really a privilege to have the job that I have.
Thank you so much, Dr. Hogg. What a great overview. And I love hearing how everyone's kind of weeks are mixed with the research and the education, and how everyone finds something that fits what they like to do. That's excellent. Thank you so much. Okay, last we have Dr. Rachel Jimenez. Dr. Jimenez is an associate professor of radiation oncology at Mass General Hospital, and she specializes in treating patients with breast cancer. She earned her medical degree from Harvard Medical School before staying in Boston to complete her radiation oncology residency at the Harvard Radiation Oncology program. And she also completed a medical ethics fellowship at Harvard Medical School. She serves on national committees in oncology, including NRG, ASCO Ethics Committee, and is also the editor-in-chief of Advances in Radiation Oncology. And she also serves in several patient advocacy organizations as well, such as survivingbreastcancer.org. Some of her clinical research include prevention of cardiac toxicity after breast radiotherapy, and she also serves as the principal investigator for multiple clinical trials in this research space. She is very invested in medical education and has served in roles such as the assistant program director for HROP, which is where I met her, as well as she's very involved with our Radiation Oncology Education Collaborative Study Group and has been the chair of that organization. So Dr. Jimenez, thank you so much for joining us, and you're up. Thank you for coming.
Thanks so much, Stephanie. And I just want to say it's really lovely to get to hear Dr. Gilbert and Dr. Hogg talk a little bit about their choices and what led them to medicine. And certainly a lot of what they said resonated to me as I was thinking about what to pursue. And so it's just nice to hear other doctors talk about their journey. So I would say the challenge with radiation oncology for most medical students is that you never actually learn about radiation oncology. As part of your core clerkships, you see medicine, you inevitably see oncology patients, you see surgery. And so you're able to make, I think, a pretty informed choice based on repeated exposure to know whether medicine or surgery are right paths for you, and then further drill down about whether oncology is the right subspecialty within those areas. Radiation oncology is somewhat unique because the residency training program directly, you're talking about tributary, it's directly escorts you into a training program that is uniformly focused on cancer. And so as a medical student, I did not have any idea that I was going to be a radiation oncologist. And the reason why I found myself moving in that direction had to do, I think, with a plethora of experiences in other specialties where I was able to pluck out the individual components of those specialties that I found most rewarding. So as a medical student, I was pretty agnostic to what I was going to do. I didn't have any preconceived notions of what I was going to focus on. But as I started on my medicine rotation, I was very fortunate to be paired with a patient for a longitudinal experience. So it was a patient who was in the emergency room who had come in with Jacksonian seizures, and she ended up having an atypical meningioma. And so I was able to actually follow her as she became not just a medicine patient, but a neurology patient, a neurosurgery patient, a radiation oncology patient. And then ultimately she was diagnosed with an intravascular lymphoma. And so I took care of this patient for many years. She actually died when I was an intern at the same hospital where I met her. And it had a really profound impact on me. Not only because she was a very special person, but because I was able to foster this really longitudinal relationship with her where I knew her family, I knew them for many years. And as each of these medical catastrophes essentially were unfolding, I had the privilege of getting to see what was going on and to be there with them. And so I think that that experience really solidified for me, not only that I was interested in oncology, but also that I was interested in longitudinal relationships with patients. And I would say that I don't know that I hewed naturally to medicine. I think I was very interested in procedures, and I really enjoyed surgery. And so I was trying to figure out, how do I marry all of these things that don't seemingly go together based on the individual specialties that I've rotated in? And so I had the opportunity to sit down with mentors at the medical school. And I said, well, these are all of the places that I really have loved in medicine. And so I'm not really sure how I put them all together. And so one of the things that they suggested was that I do a rotation in radiation oncology. And so in radiation oncology, there's a big blue book. Probably doesn't exist as a book anymore either, but it's called Hansen's book. And the Hansen book, chapter by chapter, is a different type of cancer. And it provides details and bullet points that summarize the presentation of that cancer, the side effects, how it's treated. And so they tell you to buy this book before you do the rotation. And I bought that book and I started leafing through it. And I was like, this is it. This is what I want to do. And there really wasn't any other specialty that would hand me cancer right out of the gate and allow me to just drill down on cancer and have those longitudinal relationships and factor in some of the procedural aspects. And so as I did that rotation, it really all came together for me. And then to speak to Dr. Hogg's point, there were some really impressive, really influential people that I rotated with when I was a medical student in that field, where I watched them with patients and I thought, I want to do that. I want to have that kind of impact on the patients that I get to take care of. You know, I want to be able to have these really weighty, very serious conversations with patients, but also know that I'm going to see them back again and again, where I can talk to them, I can talk to their family members, I can talk to their children, and know that there's that ongoing relationship that can persist for many years. So once I saw that in those mentors, I think that's really what sealed the deal. And so while I didn't actually do that until I was very close to my 4th year of medical school, I think once that clicked in for me, it became very natural that that's what I wanted to do. And I think that when I spoke to people about it, there were still a lot of doctors who were incredibly smart, knowledgeable people that really didn't know anything about radiation oncology. And so they would say to me, well, do you see patients? You know, do you have a clinic? And I would say, yeah, like you see patients all day. And they would say, well, like, but what do you do for them? Are you like, how is it different from radiology? You know, and these are people like lifelong physicians. So I do think that there's just a lot of mystery around radiation oncology. So maybe I can chat just a little bit about what that day in the life looks like for people. So, so I treat breast cancer primarily. And so I'm in clinic 3 days a week. And so I'm meeting new patients, usually in a multidisciplinary setting with a surgeon and a medical oncologist, 2 days out of every week. And then the 3rd day of the week, I'm usually seeing patients who are receiving radiation. So I'm checking in with them, evaluating them, managing any side effects that they have, and then also seeing patients back in routine follow-up after their cancer care. So I would say most of my job is clinically facing, clinically oriented. And my research has been clinical research as well. So I do some clinical trial work looking at cardiac toxicity, primarily with radiation. And then in addition, a good chunk of my time has been spent with education. So I was the associate program director for the residency program for several years. And was really interested, just like Dr. Hogg, in educational curricula and training and how we could enhance that and assess competency. So I've worked on curriculum development for radiation oncology students and for medical students. And that's been incredibly rewarding work. I think that it's not something that we ever get paid to do, but there is something that's just, I think, incredibly special about being able to sit down with a trainee and talk to them about what they love about medicine, what's coming easily to them, what's harder for them, brainstorming what direction they want to go in, or how can we make a concept just click. And so I think that component of education has been really like amongst the most rewarding things that I've done in my career. And some of my favorite things are actually being able to educate non-radiation oncology residents. So we do a lot of participation in breast, the breast surgeons will rotate with us, or the medical oncology fellows will spend some time with us. And I feel like I learn a lot from them. And it also fosters that kind of team dynamic that Dr. Hogg was talking about. So that's one of the things that I really love about radiation oncology, is just that team dynamic of, how do we sit down and problem solve for this patient, right? What is the right thing to do at this moment for this patient who's struggling? And sometimes the answer is not radiation. But I think that being able to have those conversations with my colleagues who I so deeply respect in surgery and medical oncology really is, again, extremely rewarding. And it makes me feel like the work that we do is enhanced by the ways in which we can collaborate and work together. And then in addition to the research and the education piece, I also have recently taken on this editor-in-chief role, but prior to that, I was doing a lot of quality and safety work for the department. So this was also pretty rewarding, and something that I don't know that medical students always see as much during their training, but really is, I think, quite important for the way that we think about enhancing medical care. And so that dealt with, medical errors that happen in the department, misadministration of treatment, misdesigning of treatment, and then how do we try to design systems that prevent that from happening again. And so I think that's another component of medicine that people can get very involved in, and could be true for any oncologic specialty, but that I also have found to be a really rewarding part of my work.
Terrific. Thank you, Dr. Jimenez. And I know in medical school, we definitely had a little bit of training on the Swiss cheese model and the fishbone analysis, but I appreciate quality and safety much more now in residency. So thank you for sharing that different aspect as well, since I don't think that most of us get to interact with faculty that are heavily involved with that. Okay. Well, Drs. Gilbert, Hogg, and Jimenez, thank you so much for giving your summaries of why you chose each of your specialties, and as well as what your kind of typical week looks like, or how your weeks have changed throughout wearing different leadership hats. Now's the time when we have an opportunity for anyone on the call to either unmute themselves and ask a question, or you can put your question into the chat and I will read it out.
I can start. I had a question. Hi, my name is Rimsha. I'm a second-year medical student. Thank you so much for just the three of you to come together and talk to us about just your wonderful, unique paths and what have kind of led you to those paths. Just a question for, it's really for all three of you, but specifically for Dr. Rachel Jimenez, because I'm specifically interested in radiation oncology. For students that are finishing their preclinical years, so they're almost done with second year, and then they're about to go into their clinical years, and they have an initial interest in radiation oncology based off of shadowing or research, but they haven't been out in the clinical force yet. What advice would you have on things to really look out for or think about? And I guess this could also go to the three of you too, because it's just interacting with cancer patients in general, but specifically more tailored towards preparing for a radiation oncology rotation.
Yeah, thank you for the question. I'm curious to hear what Dr. Gilbert and Dr. Hogg think as people that interact with radiation oncologists, and what would be valuable from their perspective. But I would say that the things that likely serve you well in radiation oncology are similar to the kinds of things that would serve you well in any oncologic specialty. So being able to be pretty well exposed to pathology, to radiology, to really understanding how those disciplines inform cancer care, I think can be quite helpful. In radiation oncology, we do so many things anatomically, and specifically with cross-sectional imaging, that being able to get some exposure to that with radiology, I think can be quite helpful. It's not that you need to be an expert in how to read things, but I think being acquainted with the anatomy, and surgery, I think, is extremely helpful in that regard. So when I was a med student and knowing that I was going to go into radiation oncology, I actually did additional electives in gross anatomy, because once you're a medical student and you're going back having done clinic, you have such a greater appreciation, I think, for the anatomy. And so it really was, I think, an increased privilege to go back and do dissections again on cadavers once I knew the lay of the land and I understood the pathophysiology, to think through that anatomy a little bit more. So, getting more exposure to gross anatomy as well as microscopic anatomy, I think can be very, very useful. But I would say in general, any oncologic focus or exposure is probably extremely helpful. Because when you step in the clinic, just having a context for, what does a Whipple look like and what do they remove? And what does that mean about where the anastomosis is located? And what are the complications that can happen are going to serve you when you see that pancreatic patient in clinic and you're having a conversation about radiation. So really just trying to get that very well-rounded view of oncologic management, I think, is probably the best preparation you could have.
I agree. And I will also, I second that. I will also say, to Rachel's point, when I knew that I was going to be doing head and neck cancer, and I was a fellow at that time, I went to the operating rooms. I asked the ENT surgeons, can I go in and see? Because the other thing I'm not great at is 3D, which is another reason not rad-onc, but I had to see it. And then I also put myself in rad-onc clinics so I could see them scoping patients as well and how they put together plans and things like that. I would go in with a sense of wonder and realize that you don't need to know it all. You just need to be interested, and you need to recognize the multidisciplinary aspects that make you the best radiation oncologist, and show interest in all of these different sort of areas as you rotate through.
Yeah, I don't think I have a ton more to add to that, except I really, that point Dr. Jimenez made about you don't see radonc as as a med student and resident, and it's almost so true, and even now the sub basement is connected to my offices, so like even in the day-to-day life, they're kind of submerged under the surface where you can't have easy access. But I definitely think figuring out who controls the tumor boards. And so typically a lot of academic places may have 9 different tumor boards, like lung tumor board, sarcoma tumor board, head and neck tumor board, urology tumor board, et cetera. That getting into the habit of knowing when during the week all these tumor boards are, and trying to go to those when you're on rotations that allow it. And also I think just with anything that people do, spending 3 months doing something else before kind of exposing yourself to what you really want to do, I think is always a good plan, so that you're kind of get the nerves out, get the flow out, get all that stuff out. You don't want to run as July, and kind of, freak anyone out. I actually look back on myself as a third-year medical student, and I'll be like, what a pest I probably was, thinking now, as being faculty, I look back and say, oh man, those residents, dealt with a lot when I was a medical
student.
student.
That. I love the tumor board. Brilliant. That's
Thank
great.
you
Show
so much.
up. Yep. Be interested. Follow the patients through it.
Yeah, and I'm certainly not an expert like our 3 panelists here, but you have opportunities like when you're an OBGYN. So if you have an option to pick an elective, pick gyn-onc, right? And so usually there are ways to sneak in a little bit more cancer exposure, and just because of the tumor boards, you'll have that extra experience with all the specialties and kind of get a better gist of the cancer journey for a patient. Okay, so we have a question in the chat from Nima, and his question is, how do you maintain a work-life balance for yourself and your specialty, perhaps especially because you all seem to wear multiple hats?
I think it's a learned skill, and I think we're always trying to figure it out. I will say I didn't do a good job when I was early in my career. I did nights and weekends all the time, and it wasn't until actually an ENT attending saw me at work, and I wasn't on service during a weekend, and said, "What are you doing? You can't sustain this. You need to dial it back a little bit." And it was sort of an aha moment of, wow, I think that's actually a good point. I don't give my cell phone out to patients generally. Unless it's a very special circumstance, and that is a boundary, I try and not work on the weekends unless I really have to, because for me, I'd rather be super busy during the week and work, 10-hour days, including my work at home, than be working on the weekend. So for me, the balance has been mindfully doing this, recognizing I'm in a very different position as a full professor than I was as a resident, as a fellow, as an assistant professor. So, I mean, you have to put the work in, but along the way, you have to figure out what is going to actually sustain you for career.
Yeah, I think for myself, I'm still a work in progress. I think that like a couple of the things is, boundaries and goals, in the sense that you may like, I always say I could work 20 hours a day and never take a day off, and I'll still never have everything done that I want to have done. So then it's really about prioritizing and what has to get done this week, what has to not get done, et cetera. So I think that you have to set within yourself the boundaries, because actually like no one else will do that. And, I have faculty that are like, I can't get my research off the ground. I do this and that. And I'm like, do you need to operate this much? Do you need to do this? And I kind of ask them those questions, because part of it is if you don't protect it for yourself, no one else will. And then also just sort of prioritizing, like for me living in Chicago, the weather's really nice in the summer. So if I can really work hard in the winter, and if I have to, do later nights or weekends, and then kind of protect my weekends and even my Fridays, in the summer, that's sort of what I try to do. And then, as Dr. Gilbert said, work a lot Monday through Thursday. So then, Friday you're done at noon, and, you're kind of relaxing and enjoying the weather when it's nice.
Yeah, I'm not sure that I have too much to add, except I will say that as the more junior person on the panel, I would say it becomes very challenging in the beginning of your career to be able to really establish work-life balance without feeling like you might be compromising something in terms of your career advancement. And so there's a lot of young folks who finish their training and they're already used to completely unreasonable work hours, right? So they've done their residency program and they've sacrificed their weekends and they become attendings. And there's this jarring moment where you go, oh, I was waiting for life to happen. And it is happening. It's happening right now. And I can either continue to work at the same pace and with the same expectations as I did when I was a trainee, or I can reevaluate those things and decide where I'm going to put bounds on. And so I do think that it has been for me quite iterative. I do something for a while and then I realize this isn't serving me. I'm feeling tired or I'm feeling burnt out. And so what else can I do to try to protect my time? And so my most recent iteration is that I don't check my email at all on the weekend, because I know that the only thing that will happen is that I will do more work. And so I really give myself permission not to look at my email until I go into work on Monday. I might go into work early on Monday so that I can stay on top of things, but that time is the protected time. And so I think everybody finds their own way of making those adjustments. But I think that it does have to be constantly reevaluated based on the other things in your life, particularly if you have a family, because your kids are going to demand different things from you at different times, and that may require you to adjust in different ways. But you just want to make sure that when you're thinking about the way in which you're working, that you're also thinking about the way in which you're parenting, and thinking about, you know, what am if I am working right now, what am I not doing with my family? And so those are just constant conversations that you have with yourself.
Wonderful. I think the email tip, everyone handles the email differently, but that's a constant struggle for a lot of us. And that is amazing that you're able to kind of prioritize your family on the weekends. I like that a lot. Okay. I have a question. And so Dr. Gilbert kind of mentioned when she was thinking about infectious disease versus oncology, how there was a lot of science and movement happening. So for each of your fields, I know some of the directions radiation oncology is moving, but you know, immunotherapy was a big new component for medical oncology. And so, you know, as this new generation is coming up through medical school, what do you think is going to be the biggest thing to change your fields in the future? Either the way that they train or kind of how they're seeing their patients or what have you for each of your specialties.
Well, so, oh, go ahead, Dr. Gilbert.
No, you go ahead. Go ahead.
Well, I mean, I do think immunotherapy is changing surgery. I mean, look at melanoma and so many other things and also neoadjuvant. I think that there are going to be a lot of things that become, you know, making surgeons a little bit more obsolete. And if it cures cancer, that's a good thing.
Yeah, that would be amazing. I think for us, it's just new drugs, new drugs, new drugs. I also think, you know, medical oncology is more and more, thank goodness, of an outpatient specialty. I mean, the inpatient, for those of you who rotate, you know, it's basically internal medicine on steroids. It's, you know, not the days when we admitted for chemotherapy in general. I also think for us, in addition to immunotherapy, it's going to be the new drugs that come out of NGS, the new targeted therapies, and the treatment for rare diseases that is systemic. But I also do think we're never going to be a standalone island for the most part. I think it's always going to be in conjunction with our multidisciplinary colleagues. So yeah, I'm curious, Radonk, what's on the horizon too for you? I'd love to hear that too.
Thank you for the segue.
Yeah.
I think it's challenging in radiation oncology because I think what we're seeing is that as systemic therapy gets better and patients are living longer, one of the first things that people do is say, let's get rid of the radiation and see what happens. And so when I was a medical student, there were people who told me, don't go into radiation oncology. The field is going to be obsolete. You're going to train and no one will ever get radiation and you're not going to be able to support yourself. And obviously that has not come to pass. And so I think that everything in oncologic care is a bit of a pendulum, right? And it's a little bit of this like balancing of scales. And so as we've seen that systemic therapy continues to improve, particularly in the neoadjuvant immunotherapy space, we're going to then have to balance that with the toxicities of those medications and figure out which patients really need those things and which patients don't. And when they don't, what are the other types of therapies like surgery and radiation that can be used appropriately, particularly in the oligometastatic setting where we've seen we're using very high doses, focused radiation, SBRT. So I think the pendulum is going to just keep swinging back and forth. We're going to see that precision get closer and closer as we really start moving the needle on longevity for patients. And so I'm not sure that radiation per se has a breakthrough. I mean, there's lots of high-tech things like FLASH and particle therapy and all of those things, which are intended to limit toxicity of radiation. But I think it's actually going to be what is the judicious use of individual cancer therapies that really is the most interesting thing in cancer care.
Excellent answers from everyone. Okay, well, it is just past the hour. I want to say thank you again for Dr. Gilbert, Jimenez, and Hogg for joining our amazing panel for the American College of Radiation Oncology webinar. I very intentionally picked an all-female panel. I love to see women amazing clinicians, researchers, educators, and are educating the next generation. So thank you all so much. Thank you for your time.
you.
And
Thanks for having
absolutely.
me.
Thank
Thank
you.
And thank you everyone for joining. Have a good night, y'all.
Great. Thank you, guys.
Thank you, Sally, for helping.